All right, let's get started. Once again, welcome to this 13th Annual International Conference on Stigma. We give thanks that on this Tuesday, we have an opportunity to discuss important issues around stigmatization as they relate to the faith community. Many of you have joined this first faith session of today, entitled Syndemics, Stigma, and Spirituality, the Intersections of HIV, COVID, MPox, and Faith. This particular webinar will explore various community and faith-based interventions to the current intersection of HIV, COVID-19, and monkeypox, with a focus on the role of faith communities in addressing the stigma inherent in the response to these colliding public health crises. My name is Ulysses Burley, and I will be serving as moderator for today's session. We have dynamic speakers who have joined us who will impart great knowledge and wisdom to us as it relates to this topic of these colliding epidemics. And we look forward to being able to engage each of you, our attendees, in this very important conversation. We are at a time in our world where we have more knowledge and tools and resources than ever before to prevent and treat dis-ease, yet we are experiencing unprecedented sickness in part due to rampant social inequality that manifests from stigmatization. These last 3 years have been years of multiple intersecting pandemics. And we are in a period where we should likely expect more pandemics, not less. Many reasons are environmental, in that deforestation is reducing the natural habitats of animals and species like never before, such that our worlds are colliding. Globalization now means that we can wake up on one side of the world and go to sleep on the other. And that means that our ability to connect with one another also enhances our ability to transmit communicable diseases to one another. Climate change has made for an environment that is beneficial to the survival of pathogens, and mass inequality that continues to persist is fueling these pandemics, particularly in communities that are impoverished. And we're clear that stigma is a key function of these disparities that we're seeing as it relates to HIV, COVID-19, and MPox specifically, particularly stigmatization of poor communities, stigmatization of communities that identify with diverse genders and sexualities, and stigmatization that sometimes manifests from a diverse array of belief systems. And so today we hope to be able to address the ways in which we can reduce stigma as it relates to dis-ease, particularly as communities of faith and in faith communities, and the ways in which faith communities can be a part of the solution in eradicating stigmatization as it relates to these colliding pandemics. And so it's my pleasure to introduce to you all our panelists for today. We have with us Elder George Kerr, who is a member of the United States HIV and AIDS Faith Coalition. George is also an elder in the Presbyterian Church and is a member of the Presbyterian HIV and AIDS Network. We also have joined with us today Dr. McKinney. Dr. McKinney is the Chief Business Officer and Public Health Project Manager for the Vision Community Foundation in Atlanta, Georgia. And we're going to hear more about Vision in just a second. And finally, we want to welcome Mr. Kurt Myers Hill, who is the founder, president, and CEO of Abounding Prosperity Incorporated, based in Dallas, Texas. And so let us jump right into the questions for our panelists. Today's discussion will be conversational. And so I will pose some guiding questions, if you will, for each of the panelists. And then we expect our conversation to organically evolve into a fruitful discussion that I am sure will benefit all of us. So let's get started with you, Elder Kerr. You've been engaged in HIV advocacy since the beginning of the epidemic on a community level and within the faith community. And you continue that work as other public health threats like MPox emerge. Looking back to then and now, what have you learned about the impact of stigma in responding to pandemics that can help inform how we should be moving forward?
Thank you, and good afternoon to everyone. I want to first start off by saying that I've been living with HIV for over 27 years. And so I've seen a broad range of stigma throughout the 27 years. And so as we are beginning this conversation, I was thinking about the early days of HIV, which some of us know, not all, that it was referred to as GRID. And when the outbreak of MPox happened, it was where we were reliving that stigmatization. And I say that because on June 28th, I was headed to a church conference, and I got an email from the DCCFAR, Center for AIDS Research, saying we need to do something about MPox. And everyone else was calling it the full name monkeypox. And I made the conscious decision that I'm not going to add to the stigma to call it that. So you will hear me refer to it as MPox. At that time, we only had 5 cases. And then we grew very rapidly. And after just a couple of weeks, then we saw where LabCorp, who draws bloods at most of our primary care facilities, refused to draw the blood. They said they were putting their phlebotomists in danger. And that went on for a couple of weeks. And it reminded me of the early days of HIV where they wouldn't draw the blood. And I remember going into a doctor's office once, and the nurses wouldn't even come into the room. The doctor talked to me outside the office into me. And so I felt like, I continue to feel that stigma is still rapidly happening, that there was a misstep in public health messaging when MPox came out. There was a misstep with public health when COVID happened. And there was a lack of information for people living with HIV in the early days of COVID. So after 40 years, you would think that we would be able to address this, and we keep having these missteps. Thank you.
Thanks for that, George. Something that really stood out for me was your delineation between the use of monkeypox and MPox. And you started with a history lesson around the nomenclature for HIV as being first GRID. And for those of you who are not familiar, GRID is an acronym that stood for Gay-Related Immune Deficiency Disease, because at the time, scientists believed that HIV was only a disease that was impacting same gender-loving people. Obviously, we later found that not to be true. But in and of itself, the naming of HIV as GRID was stigmatizing. And you note how monkeypox, while maybe the same energy wasn't there in the naming of monkeypox, understanding history and the legacy, particularly of communities of color and even more specific, Black people. Monkeypox can be problematic, especially when we are talking about communities who are most impacted being people of color, and more specifically, maybe men of color. And so you raise up an issue of what we call language justice. And language justice is a way in which we can, right off the jump, reduce stigma around some of these conversations by just being mindful of our words, because we understand that words have power. The other thing I heard from you is that in the 40 years since we've identified HIV, we maybe haven't learned as much as we thought we had in terms of the ways in which we should be responding based on your experiences then as a person living with HIV, and now as a person who themselves were seeking treatment, prevention for MPox, and receiving some of the same types of treatment as you did nearly 40 years ago. And so that's something for us to be mindful of. The last thing I heard you talk about was public health communication, and we can probably have an entirely separate discussion around how we can better communicate some of these complicated, complex public health messages. I think one of the main failures of our COVID-19 response was messaging, and that's something to be mindful of here as well. So I look forward to continuing to dig into the history and the legacies and how those are manifesting themselves today in the form of stigma, but the ways in which we can overcome those histories and legacies as well to move forward. Dr. McKinney, I want to move to you for a second. You serve at the Vision Community Foundation Incorporated, which is an Atlanta-based nonprofit organization that addresses health gaps under your leadership. And perhaps what's most significant to this conversation is that the foundation emanates from a church that is radically inclusive and prioritizes HIV and AIDS as a ministry. As we talk about the intersection of stigma, disease, and faith, how has Vision been able to do what other faith houses often fail at in offering both expertise in these key health areas without the associated stigma that sometimes accompanies churches?
Thank you, Dr. Burley. So one thing that we try to do at Vision, not only at Vision, because one signature program that we have through the Vision Community Foundation, outside of the Vision Cathedral of Atlanta, but our foundation, is education as it relates to prevention of HIV. We have a Prevention from the Pulpit initiative, which is an evidence-based training that is centered on faith and directed towards faith leaders. And it helps to integrate the faith leaders' call with their call to decreasing HIV stigma. And we do that by education. Through our church and through our foundation, we teach faith leaders what is stigma, teach them to investigate their own internal biases that are contributing to stigma. We provide them with strategies to model inclusive behaviors towards people with HIV that are living in their communities or part of their congregation. We challenge them to then identify community partners where they live that could then come in and talk to their church members about stigma if they're not comfortable doing so. So we kind of do a multi-layer approach, but all of it is based in education. What we found is that stigma reduction is easier when we're working with communities that reflect the communities in which we're trying to reach. For instance, it has been we've had a much greater impact when faith leaders are same gender loving, and they're trying to reach out to same gender loving people in the community. So having leaders that reflect the community in which you're trying to reach is also paramount and decreasing HIV stigma. Because if I can see someone that looks like me, who lives like me, talking about these topics, I'm more likely to listen, more likely to take note of what they're saying and implement whatever strategies they're talking about and they are suggesting for me. So those are some of the main things that we've done at Vision.
That's awesome. My granny used to say, if you know better, you'll do better. And so it sounds like you all are helping people to know better with the expectation that as a result of the education you're providing, they will do better. A question that I'll have for you is how to actually get those faith leaders to the table, which is a challenge I know that I've experienced in my own work and ministry, and we can address that question as we continue to have our conversation today. Mr. Kirk Myers-Hill, your organization, Abounding Prosperity, focuses its outreach on supporting men, particularly Black men, and even more specifically, Black same-gender loving and or queer men. As a primary resource for same-gender loving Black men in the Dallas area, how has Abounding Prosperity managed an ongoing HIV epidemic amid an emerging MPox crisis that has disproportionately impacted and further stigmatized this population of same-gender loving Black men? And how have you partnered with faith communities in your response?
Well, that's a lot to unpack, but yeah, and we do serve Black men and their families with a particular emphasis on gay, bisexual, and transgender individuals. But the key word here that I wanted to make sure that I added before I get started was families and family. And so the way that we were able to manage all of what's going on now, COVID, monkeypox, HIV, all of these things that are disproportionately impacting Black families, we managed through existing trust and rapport with community. So that was the backdrop of everything and all the efforts that we were able to do here and are continuing to do here successfully in Dallas. We use the lessons learned, like my co-panelist George, we use the lessons learned from HIV to mobilize. So maybe whereas the Black community wasn't as responsive initially, specifically the same gender Black MSM community, maybe did not mobilize in the same way initially, I felt like we had opportunities, and I built on this with COVID and now MPox. And so we were able to use all of this last almost 40 years of data and knowing what inaction would cause to be able to say, hey, these are the things that we are going to do and needed to do in response to all of these co-pandemics, epidemics, and any epidemics that we like to call these things. And so one of the things we did was focused on vaccine equity, because again, that was a big issue, who had access to vaccines. So with us, we had to lobby really hard and talk about, hey, vaccine, this is inequitable. You're having it in areas that are not accessible to the communities that are certainly always disproportionately impacted. So we had to, talk with local, state, and national representatives about access, and whether it be COVID or MPox, and also helping them understand that, we have to provide services in the backdrop of what's convenient for our target populations, not convenient for staff and health departments and those sort of things. So that was the other thing that we had to help them understand, because all of those things work in tandem to remove stigma as well. I mean, if it's only in the north side and everybody that possibly needs it on the south side, that's stigmatizing by itself and all those sort of things. And so vaccine equity was one, access was the other, but then two, which is why I made the family point, again, the Black family is under assault, Black and brown families, but I'm speaking specifically for Black today, is under assault at multiple entry points, right? And so for us to remove stigma, one of the ways that we remove stigma was, again, addressing the entire family, and how if one portion of the family was impacted, then the entire family was impacted. And then we bring that forward with the faith community. Again, that was the same thing. If one person in the church is impacted, then it could potentially impact everyone disproportionately. But one of the things that we had to do as it relates specifically to COVID, and we modeled this same approach with MPox is the community came to us because of the trust and the rapport, and they needed information first. So, people were not necessarily talking about a vaccine on either sort first, but how does it impact them? People were worried about work. A lot of our community oftentimes are gig workers and those sort of things. So what we were able to do for COVID and MPox was to have gift cards available for those people that were impacted financially. We had COVID care and prevention kits. So if someone was impacted with COVID or had contracted COVID, we had a care kit, which has specific things around care. And then we had a prevention kit for those to prevent, because in the initial, there was a shortage of gloves, there was a shortage of PPE, all those other things. But we also were feeding communities, and that's where the faith-based community came in, because we were feeding every weekend, and we were able to get various churches involved. I mean, we had some churches that are extremely conservative that were out here passing out, food boxes. And so we replicated the same thing for MPox, and we've had the same result. But also, because there was such limited access to vaccines on both parts, then, churches were, working with us to refer, because the church is a trusted source of information too. And oftentimes congregants were, asking what to do. And so because we had these existing partnerships, they were able to make referrals that also reduce stigma, because it's saying, hey, this is a health issue, not as much of anything else that could create, stigma within the church environment. And so I think that was really helpful. But I also think that us really focusing on family certainly allowed us to have some successes that we can talk about more if you guys like. So I think I answered the question.
Yeah, no, that's excellent. And I think I have a lot of follow-up questions.
Okay.
As a note for those of you who are attending and listening in, we will designate the last 15 minutes or so of our conversation for question and answer. And so we hope that any pressing questions that you would have throughout the conversation, that you could put a pin in them, and we'll make sure that you get your question answered during the question and answer session. So Kirk, I heard a lot of different themes in your comments. You talked a bit about the importance of families, which I think is important, especially in the context of Black people, and even more specifically, Black same gender loving folks, because they have families too, right? And the health of one impacts the household. And I think it also helps to humanize people who have often been dehumanized throughout histories, to know that they have loved ones and people who are counting on them. So I appreciate that perspective. But you also talked about vaccine equity. And one of the prevailing narratives, especially throughout mainstream media during the early days of the COVID-19 pandemic, were that Black people in particular were more vaccine hesitant than other folks, that they were rejecting the science and the vaccine and therefore not participating in it. And that just wasn't the case. It just wasn't true. It was
not true.
It was more so around access,
Absolutely,
and equity and information, to your point. It wasn't that Black people were more hesitant than other groups of people. It was just that we needed more information to be able to understand what it was that we were participating in. And then the research shows that once we had the information that we needed, we were overwhelmingly participating in vaccines when we were able to access them. And so I appreciate you framing that portion of the conversation, because it's very relevant to our conversation about COVID, but also now MPox.
Absolutely.
Because everything that I've heard is that there hasn't been vaccine hesitancy around MPox. People are looking for the vaccine if they've been identified as folks who might be at an elevated vulnerability for MPox. It's just a matter of which, if they can get it or not, if they can access it or not. have you had any of the, I'm not sure about this, you know, where did the MPox vaccine come from or whatnot, or has it just been people just trying to get what they need to help them be healthy?
So I'm smiling because interestingly enough, with COVID, the COVID vaccine, I want to start there first because you mentioned it. I could say that there was certainly some hesitancy as well, but it also was access. So, because again, at least in Dallas County, you know, rich, predominantly white zip codes was where the vaccinations were occurring, and so you had a higher uptake of white people, but that's based on location and how they were administering and those sort of things. So I think it was less again about hesitancy, but again around access. So I just want to reiterate that. Now, we saw something interesting around monkeypox, as many people that may have been hesitant around the COVID vaccine, we didn't find any hesitancy around monkeypox, or very low. And so we coined this phrase, well, you know, it was more of a vanity thing. I think people were certainly much more concerned about, you know, I just absolutely can, I mean, these were quotes that I just absolutely cannot, I would just die if I walked around with, you know, monkeypox, signs of monkeypox, or the visible signs of monkeypox. And so we also use that to reduce stigma. So, and I know that you mentioned that this wasn't in the question that you asked, but I wanted to interject this into the room. We also use monkeypox, the willingness to take that vaccine as an opportunity to connect the benefit of a COVID vaccine, the benefit of an HIV or STI test, because again, oftentimes the risks for all of them were relatively similar in some regard, but certainly around monkeypox or MPox, I'm sorry, and HIV. And so what we found is that we were able to identify a high number of people unaware of their HIV status based on them coming in seeking an MPox vaccine. And so now we really created, I know that there's a buzzword about integrated screenings, but we now have a real scalable integrated screening program where, again, removing stigma is we're not necessarily leading with HIV or COVID or MPox. It's whichever point of interest, then we can talk about the other connected vaccine opportunities and our treatment opportunities and our screening opportunities.
I love that. Creating opportunities from other opportunities, if you will.
And it reduces stigma too.
Right, and it reduces stigma too. The final thing I want to know that you mentioned that I think is important for our conversation is that you partnered with faith-based communities to maybe do things that were outside of direct care for HIV or COVID or MPox. It might have just been feeding people or providing other necessities that people have. I think sometimes we often neglect the fact that a lot of our communities are reeling from daily challenges of survival.
Absolutely.
And if you don't know where your next meal is going to come from, you're certainly not focused on your HIV status or your medication or a vaccine. And so by meeting the needs, the basic needs of our communities, we then give them agency to be able to prioritize other things like their health, that then also gives us access to then be able to test them for HIV maybe for the first time when they hadn't been able to do that. And so I think for faith partners who are listening and feeling far away from this conversation, one of the points I'd like for us to take away is that you can impact these syndemics, if you will, indirectly by doing basic things that many of our faiths call us to do, to feed people and to clothe people and to house people, because those all become social determinants of health that further impact people's vulnerability to disease like COVID, like HIV, like MPox. And so your health ministry might not be a health ministry at all. It might be a feeding ministry, that then gives you entree into the opportunity to be able to engage people about their health as it relates to some of these intersecting pandemics.
Thanks for adding that. The other thing too, that what we were able to do, I didn't mention, and you just jogged my memory, a lot of the churches already had existing rental assistance, housing type programs, clothing and food banks. So again, I think oftentimes people think that you have to agree on doctrine. And I don't think, I think that we have, you know, MOUs and MOAs in place with, you know, again, some of the most conservative entities here. But again, we're not necessarily focusing on the things that divide, but on those commonalities in kingdom building. Let me say it like that.
Yeah, I love that. George, I want to shift back to you and then Dr. McKinney, specifically around MPox. George, for a long time, and it might still be the case, I'm not sure, DC had the highest rate of MPox infection per capita, to be clear, in terms of population. And you have been among the leading community members in mobilizing the MPox response. Tell us a bit about what that has looked like, especially for you as a person of faith who, you know, originates from a faith space as it relates to HIV and AIDS. And then Dr. McKinney, I'm going to ask you a similar question because the last time I checked, Georgia had the most cases of MPox as a state in our country, and how it is that you all are meeting that need in the Atlanta area. And so, George, love to hear from you.
Well, it was interesting because I was listening to Kirk talk about his experience with MPox, and I found it total different here in DC. There was a lot of hesitation. And then all of a sudden they said, okay, we got a vaccine. Well, how in the world did you get a vaccine so quick without, you know, any knowledge of the virus? And also, you know, we're 40 years into HIV and we still don't have a vaccine for that. And then all of a sudden you got one for us. And so I heard from many of my community members that they weren't ready. So there's education that needed to happen. And it did happen, and the numbers have went sharply down. And so I'm really happy about that. But I think that there's still education that needs to happen, because getting into the root of getting down on the ground here in DC is so important to educate our communities. I've heard stories of individuals that said, well, I'd rather isolate at home for 28 days than go to the doctor to find out if I have MPox. And so I think that some of the numbers that we're seeing, we may not actually know the true numbers because of the stigma that's associated with that. And I know I'm connected to an incredible health care system, Whitman Walker Health, and they have been extraordinary. But if you go outside of there to the general public, I don't know if you would get the same service, if they would be asking the same question. I heard many times, particularly in the early days of MPox here in DC, where Black women were extremely upset because all the focus was on white gay men. And so they wanted to be brought into the conversation how to protect themselves. And so I think there's a combination of a lot that needs to happen, community education leading that effort.
Yeah, it's the tale of two different narratives between the one you shared and the one Kirk shared, and a narrative specifically that we're familiar with in HIV in terms of the response to white same gender loving men and not necessarily Black women, who for many years the leading cause of death among Black women who were within reproductive age was HIV. So that's important to note.
Let me just add to that also, because we're still dealing with PrEP and the lack of research and the lack of education to Black women and them wanting to be at the table to be able to get that opportunity. And geographically where you're located, because we now know that in Texas, they've stopped PrEP being offered by some healthcare providers because of religious freedoms. And so we're constantly fighting to be able to get to the table, everyone that is needed to be at the table.
For sure. Dr. McKinney, you are based in Atlanta, Georgia, which is home to the CDC, home to a lot of historical Black churches, home to a lot of historical Black colleges. But in Georgia, which has the greatest number of people impacted by MPox in the country, has, you know, a social political landscape that might not necessarily give way to things like Medicaid expansion, those types of things. And so in the context of everything I mentioned and these emerging and colliding pandemics, how important has it been for a place like Vision to be able to fill those gaps? How have you all managed to respond to and partner with others to respond to the health and justice needs of people in your reach?
We've done a couple things. So from our HIV work, we built strategic partnerships. Those partnerships were with places like Fulton County Health Department. And during COVID, because we have the largest same gender loving faith community in the state, well, in the city, they would come to us and say, hey, can you all help us get access to these people? Can we help them get vaccinated? And this was during COVID. So we actually had vaccination clinics at our church for our community, for our members, for anyone that wanted to get one. We shared that broadly on social media. So when monkeypox came around, Fulton County came to us again, said, hey, can you help us reach this community? So they're in that particular space through that strategic partnership that we built based on HIV work. We were able to then have access to monkeypox vaccines for our members and for our community. So that's one thing that we did, strategic partnerships. The second thing that we did is that our leader, Bishop O.C. Allen, has always been a champion for faith leaders using their voice and their influence to improve health. One thing that we can tell in the data is that Black people, same gender loving Black people are no different. They revere their leaders. And if you can get your leader on board to tell your congregation why this is important, that is 95% of the battle. And speaking openly and honestly and having your leader speaking openly and honestly and being educated about the topic, 95% of the battle. So those are two things that we've done fairly effectively at Vision. Education, strategic partnerships have been key in what we've been able to accomplish through our church.
Thank you for that. I think level setting is really important in terms of the identity politics that takes place in our country, and particularly in the southern region of the United States. The southern region of the United States has the greatest number of people living with HIV. It also has the greatest number of persons who self-identify as LGBTQIA+. But it's also the most faith-oriented section of our country as well, right? And so you've got these interesting intersections of faith, identity, economics, where majority of the southern region of the United States are considered to be below or at the national poverty level, illiteracy, so on and so forth. And so everything that you all have to do to address dis-ease is in the context of your location. And Kirk alluded to how location can in and of itself be stigmatizing earlier in his comments, just from access and equity. George talked a bit about it as well. I've seen it in my own communities, during the COVID-19 pandemic, when I was going to seek my own vaccinations. As a clinician, as someone who at the time was working with the COVID-19 Prevention Network, which was responsible for evaluating all of the government-sponsored COVID-19 vaccines. And I was going to my local Walgreens in my community on the south side of Chicago, which is predominantly Black, and hordes of white people who I've never seen in my community were there lined up to get their vaccines. And it became clear to me, again, how location was playing a role in equity in that way, and how location in and of itself can be a barrier that promotes stigmatization. And I'm well aware of the circumstances under which vision is operating because of location, and how you not only have to care for people, but you have to do it in the context of all of these social determinants of health around access to information, diverse belief systems, diverse identities. You made a point about the faith and spirituality of same gender loving people and how it's as strong as anybody else's faith, and particularly linked to a charismatic leader, if you will, like Bishop O.C. Allen. We have data that suggests that that relationship can go both ways, and that same gender loving Black men, for example, who have a history tied to the Black church, were more vulnerable for HIV transmission than same gender loving Black men who did not have that, because of that same dynamic and that same relationship. And it was a function of what they were hearing in their faith communities that was stigmatizing their identity, that further pushed them into a vulnerable place to disease like HIV and AIDS. But at Vision, we see how that same relationship can be beneficial, can be protective, if you will, based on the messaging that's coming from the pulpit, that's coming from the leader. You can turn that stigma on its head to further engage people around their health. And so I think it just highlights again that the importance of the role of faith communities in eradicating stigma around these health issues, just because of the relationships and the power that faith leaders still possess. Really amazing work you all are doing in Atlanta and DC, as well as Dallas, in some challenging environments, might I add. So as we enter into about the last 30 minutes, 20 minutes or so of our conversation, we are starting to get some questions that are coming through. And I want to start to share those with you all, because some of them are in the context of some things we've already discussed. One of the questions we have here is around the sentiments of Black same gender loving people. Why do we feel there's so much stigma to Black same gender loving people? And I will open the floor to anyone to be able to respond to that question. I think I'm pretty sure I know the answer, but some of you might have different answers. Why there's so much stigma directed towards Black same gender loving people?
Well, from a preacher's kid who was raised in the Black church, and I am same gender loving, there's so much stigma because that's what people are taught to feel. We're taught from day one that gay is bad. And so that is just perpetuated generation after generation. people believe that just because they were told that. They have not investigated scripture. They have not antagonized what their thinking is. They've not spent any time using their brain to think about these things. It's literally just following what they were told. And Bishop says all the time, when you come to church, you should bring your brain and your Bible. And people just haven't taken the time to do that. And I have had my personal experiences of, I don't even respond to my family's concerns anymore. I have decided that the only opinion of me that matters is God's. And I encourage everyone else around me to operate in that same vein with their family. Respect, let them believe what they want. However, live your life as dignified and the way that you would like to live, and not let that bother you. But the reason for the stigma is all rooted in doctrine. I won't even say scripture.
I love that. And I agree. Kirk.
Yes, I just want to say again, a lot of it is left to doctrine and church positioning and teaching. And I think a lot of people certainly have, certainly Black and brown people have been influenced by the church if they were raised, or certainly in these southern states, parents, teachers and thoughts and all. So I think that a lot of that contributes to, the stigma, and then, all the fire and brimstone and all those things that are promised certainly can make people not live and be their authentic selves. And so, and I think it's also just sometimes about not necessarily understanding. So back to what we were talking about earlier, when we have opportunities to work together amongst the things that bind us, then I think that it creates opportunities to have understanding and reduce stigma by people, not being divided or so divided.
Yeah, I think it's interesting that both of you, in a sense, couched your responses in the context of doctrine or scripture or faith, even though that wasn't necessarily a part of the question. And so I think that's important for this conversation that we're having at these intersections of faith, syndemics, and identity, if you will. Here's a question all the way from Uganda. I'm grateful to our religious leaders that they are taking up the role of educating the society on such matters in their own space. However, there's still fear of them talking about this openly to the young generation because it feels like they're misleading the young generation. So their education on this matter is not deep, it's more sugarcoating. Any of you, how would you all respond to that comment, more or less, than a question? But I think the question within the comment could be, how do faith leaders get more courage, like a Bishop O.C. Allen, to be able to openly discuss these things, particularly with the younger generation, without feeling at odds with their faith or their call or their scripture or their sacred text?
I know I'm an epidemiologist by training, so I lead every conversation with data. And I feel like if I can impress upon a faith leader what's happening in your city, this is a problem for you in your city. These are the people that you pastor that are having these issues. And I'm demonstrating that with actual data that helps them to then, I guess, humanize it, if you will, in ways that they feel some level of obligation to address it. It's no different. I try to equate it to being, it's no different than cancer, the cancer drive that you have. It's no different than you having somebody come in and talk about heart disease. It's no different than you having, a health fair. The only difference I'm asking you to do is to have a health fair and add HIV screening to it. That's it. It's the same premise. You're looking at all these other conditions. You're talking about them, about diabetes and healthy eating. it's the same thought process that goes into talking about HIV. It's also a health condition. That is not it's not the reason that they have it. It's not for their own, their own decision making or what they've been doing or their behaviors. You don't blame the person with cancer for getting cancer. Why do you blame the person with HIV for getting HIV? So that is how I start the conversation. And then I try to take it one step further and say, didn't God tell you to look out for the least of these? What is different about this group? So that's how I start the conversation. And it usually leads to more questions that I'm then able to draw them in that way.
For me, I think we need to talk more about sexuality and sex. I think that we want to shy away from that. And that's a dirty thing that's over there that we do behind closed doors. And we're not having an open, honest conversation about it. And so until we start doing that and having honest conversations about our individuals, we're not going to be able to address these issues.
Yeah, and talking about sex and sexuality, not just as a standalone, but as gifts from God, I think, which is important as well.
Exactly.
Thank you for those reflections, and we have others that are coming through. One from the chat: God gives us enough sense to take care of our bodies, but sometimes we think prayer is enough. Sometimes prayer needs the help of meds like COVID vaccines and MPox vaccines and HIV medications. Why do some think they can just pray this away? And I think that goes back to what I've heard about doctrine and scripture, because a lot of that is what has been taught. But to the commenter's point, I'm a physician who does work in the context of my faith. And oftentimes people wonder how I managed to marry the two. And my response is always simple, is that for me, they are one and the same. Healing is one of the most prominent themes in all sacred texts. And the pursuit of life and life abundantly is something that all public health and all medicine strives for. And so for me, they're not adversaries, they're one and the same. And one doesn't cancel out the other. And so giving credit to science, if you will, doesn't cancel out the importance of the sacred. And in fact, I view science as being sacred. God gave us these tools, these resources, these vaccines, these life-saving medications for us to then be able to do the healing work that God has been able to do in scripture and in sacred texts. And so again, to the commenter, I think it's just a matter of reimagining the ways in which we interpret sacred text, to be more inclusive of these gifts that God has given us to keep ourselves well, to protect ourselves, and exercising those gifts in honor of whatever it is or whoever it is we worship or look to in a higher place. Let's see, we've got another question.
Also, Ulysses,
Oh,
faith
yes,
without
please,
work.
Kurt.
Also, faith without works is dead. So
Say it.
just want to add that.
Yeah, I've been preaching about praying with our legs lately, especially as it related to voting and our election cycle. Sometimes you got to put some action in your prayer. So I appreciate that.
I think it's amazing to me how people limit God too. Like, if God is omnipotent, why would God only use one vehicle to heal me, which is prayer? Why couldn't the healing also come in the medication or a pill? Why would God limit God's self into one vehicle for healing? That doesn't, yeah.
Yeah, I feel the same way about who God loves and who God doesn't love, right? I think we make
Agreed.
God really small when we say that God is only capable of loving cis, heteronormative people not living with dis-ease, so on and so forth. I think we really limit the expansiveness of a God who really has the capacity to love any and everybody. So I appreciate that. There's a comment here that I want to particularly lift up from a cis heterosexual woman who says that we seem to always focus on same-sex loving people while cis heterosexual men and women are silently dying on the pews. And she wants to speak a bit to that demographic. I know, Dr. McKinney, both of us being public health professionals, and you talked about starting with the data. And you know, there's a saying in public health circles about follow the epidemiology. And for all intents and purposes, following the epidemiology supports the focus that we give to same gender loving communities, particularly around HIV and now MPox. But because I do this work at the intersection of science and the sacred, I also understand that there's a component that goes beyond what just the information says, and that component is inherent in stories and the ability to see the data and interpret the data, but also to understand the stories outside of the data, and that within those stories are cis men and women, heterosexual men and women who have also been impacted by these diseases, and these disparities, if you will, and continue to be sometimes stigmatized in the response, right? If you are a person living with HIV, for example, who is not same gender loving, but all of the commercials that you see on TV now, especially around PrEP or you know, antiretroviral therapies, are specifically targeted toward a demographic that you don't represent, then you might feel hesitancy in taking control of your own health because of associations that might be made about you, or otherwise. And I can tell you, this is something that I've experienced as a cis straight man not living with HIV who does this work in terms of being, you know, misidentified as homosexual or otherwise, just because of the type of work that I do. So I know how it could probably be problematic for people who are in fact living with HIV and who are seeking resources, but who don't want to necessarily be stigmatized in that way. And so, you all have any comments or any wisdom about the ways in which we can better accompany those who might fall outside of the epidemiology, if you will, when talking about these syndemics?
Well, what we have found is just having conversations. I mean, whether it's with cis women, and I agree with you around messaging. Again, this messaging coming up, but you know, and so we obviously now, as an organization that started out serving MSM, but have progressed to, you know, Black and brown women, cis women, trans women, Black men, cis trans. It's about taking that time to have those necessary conversations and helping people understand how this could potentially impact them. And so we've gotten a lot of buy-in that way just by having those, you know, not necessarily just the educational conversations, but those conversations of, you know, why does this make sense to me? Conversations. And we found that a lot of people aren't willing to necessarily create the time to have those, but they can be tremendously impactful.
Yeah, I always say the statistics, information informs, stories transform. And we want to move from the transactional to the transformational, and that happens through relationships. It happens through the sharing of stories. That's how we build empathy for one another, especially for people with lived experiences other than ours. And as noted by my colleague, Dr. Dave Barstow, in the comments, the HIV and AIDS epidemic particularly looks very different in different locations. And so here in the United States, it's an epidemic that has largely impacted the LGBTQIA plus community, whereas in sub-Saharan Africa, for example, it's an epidemic that largely impacts women and children. And so then the response sometimes looks different, especially as it relates to faith, because I'm sure you could imagine how it might be more comfortable, if you will, to minister to women and girls than, say, the LGBTQIA plus community. So it again goes to the conversation around context and demographics and location, and how sometimes even that stigmatizes folks. Dr. McKinney.
Carly, can I say something about that? One thing that we encourage through our Prevention from the Pulpit training course that we do for faith leaders is we understand that you may not be comfortable talking about these topics, or you may not be well educated or as well educated to talk to them intelligently. So what we try to do is connect these faith communities to community-based organizations that do have that language, that can speak to those specific inequitable communities that they may have in their congregation. There's one community-based organization here in Atlanta called Sister Love, and all they do is talk about cis women, HIV. So those are avenues in which faith leaders can use to get their information to their congregations. They don't necessarily have to provide it themselves, but just having the connection, strategic partnerships with people who can provide that information is paramount.
Absolutely. I want to wrap up our conversation as we are beyond the hour. Go ahead, George.
I've had just one more comment. We haven't mentioned it much, and that's mental health. And we need to be keenly aware of the mental health crisis that's going on around the United States and that. And I had the pleasure of doing the mental health first aid training that the International Stigma Conference offered. And if you are not aware of it, it's something that you need to become aware of and to take action and put your faith to work with that, because it was really eye-opening for me as someone that suffers from depression and anxiety. And so just a plug for that program that is really important for our community.
Yeah, absolutely. And I know that there's a lot of mental health focused programming for this week, as we know that there's stigma inherent in mental health challenges as well. So thank you for lifting that up. I know at least one of our panelists has to go to do this in another conversation. And so I want to allow for Kirk to give us some final thoughts. And then we will let him go, and then we will address the last couple of questions that have been presented, and we'll close out. Kirk, you have the floor.
Thank you guys, first of all, for having me and having this conference, because I think it's important, necessary work. And I think that my parting thought, I hadn't given any thought, but in consideration of what I would say, but if I had to say anything, I just want to continue to say that if we continue to focus on the family in its entirety, the Black and brown families in their entirety, then I think that that can certainly help us continue to do the work that we need to do going forward.
Thank you for that, Kurt, and thank you for the work that you continue to do with Abounding Prosperity in the Dallas area. Take care.
Thank you.
Okay, we've got a couple comments that have come through. One about the growing need for us to really coalesce our efforts, particularly around HIV, to not just respond to marginalized groups, if you will, or the groups that the epidemiology has identified, but doing so as if HIV is a human health condition, which it is, and I wholeheartedly agree with that. And I think one of the ways in which we do that is by reducing the stigma inherent around HIV and the communities that HIV disproportionately impacts, such that we can elevate it to what Dr. McKinney referenced earlier around cancer, if you will, to where it's a conversation where the same kinds of responses that we have for people who are living with cancer, we can have those same kind of responses for people who are living with HIV, which is a response of love and care and empathy. Totally agree with that. And I want to, there's a comment that came through from a Black woman who's a psychiatrist, but is also an atheist. And she's new to HIV and AIDS work. She knows her discomfort with this particular discussion because it presumes that Black people and people in general identify with or worship a God, which I acknowledge. And nonetheless, she's trying to figure out how to help and best interact with her clients, her patients who've been traumatized by the church, who've been traumatized by stigmatizing faith, to try and find where they fit into the paradigm. Do you all have any wisdom on that? How does someone who doesn't necessarily identify with a God per se help accompany those who they are caring for, who very much so have an experience with faith that might have been stigmatizing or traumatizing and relates to their care and the care that they receive?
I don't think church hurt or church trauma is any different than any other kind of trauma. So I would say you treat the trauma as you would any other kind. What I do know is that people who are often traumatized by the church in the Black community they don't necessarily go to I'm agnostic or I'm atheist. They go to I don't want to deal with church. They still believe in God. They still probably reverence God. They just don't want to worship God in any kind of context that is organized religion. So from your vantage point as an atheist, I would just encourage you to talk to them about their internalized stigma that has come from their experience with church. That is going to be the best way for them to gain the healing that they need, is to address that. What have they been taught that makes them hate themselves? So that would be my advice.
Yeah, I can say as a clinician who is also a person of deep faith, but was trained and reared into a profession where atheism was prevalent. A lot of my professors and attendings were very open about not necessarily identifying with the God, and some of them openly rejected the faith expressions of other, namely patients, and that made me uncomfortable to be a clinician in those settings and to see people's faith actively be rejected. And it's one of the reasons why I do the work that I do now in the context of both the science and the medicine and the sacred, to be able to both acknowledge the humanity in those who count on a higher power in addition to the science and the medicine to make them whole, while also understanding that there will be people who don't identify. And how do I, as a person of faith, make sure that I can accompany persons who don't necessarily believe what I believe in the way that I believe? And so I think it's an exercise in listening and learning and vulnerability, and being a part of conversations like this that might make you uncomfortable. But I believe that life happens outside of our comfort zones. And I'm really grateful to all of the attendees, to all of our panelists who have given of themselves and of their time to be able to disrupt, if you will, this conversation around syndemics, stigma, and the sacred as it relates to HIV and AIDS, COVID-19, and MPox. George, do you have any final remarks? And then Dr. McKinney, we'll get your final remarks and then we'll close.
I just want to say thank you to everyone that attended this session. I think it's very vital that we continue having this conversation and we keep educating each other and learning from each other. So thank you.
Thank you, Dr. Burley, for having me. I've really enjoyed this conversation. And I just, again, would encourage people to learn where you can and learn so that you can help someone else. So I appreciate this conversation, and I think it was very enlightening and very informative. And I hope that everyone took something away from this they can then impart in their lives and hopefully improve the lives of those that they come in contact with. Thank you.
Tell our participants where they can reach you, maybe social media or email, if they wanted to follow up with you after this session.
Sure. So you can reach me on Instagram at Dr. TL McKinney, and that's TLMCKINNEY, DRTLMCKINNEY.
George?
I would just say go to my profile in the app, and there's all my social media there, including my LinkedIn, Instagram, and Facebook page.
Awesome. And I am Dr. Ulysses Burley, founder of You Be the Cure, and currently serve as project director of the HIV Vaccine Trials Network Faith Initiative. I invite you to engage with me on social media at You Be the Cure, or visit the hvtn.org, where you can learn more about our Faith Initiative and the ways in which we are bridging the gap between the science and the sacred as it relates to HIV and AIDS antibodies and eventual vaccines. And I want to thank each and every one of you for your time, for your questions and your comments, and invite you to continue to engage in these comments in our second phase session that will happen this afternoon at 4 p.m. Eastern time, which will focus on the experience of local faith communities in addressing HIV-related stigma. That faith session will be compelling, and it will address stigmatization in faith communities, both in the United States and abroad. And so do come back and join us to continue these very important conversations. Again, I thank you. I thanks to the planning team of the International Conference on Stigma for continuing to make space for faith, and take care.